Those who know me, yes, I'm a vice chancellor, but I spend a lot of my time talking about sex. I have reduced my practice after I got my fellowship in sexual medicine to seeing patients with sexual problems. And I think I'm, unfortunately, the only doctor focusing on that currently. And I'm hoping my colleagues will join me to talk more about sex. So let me just read my stories and then conclude. And I want to give a disclaimer that these are real life experiences, but I've changed a lot of things in them. So data security, there will be no person you can identify using these stories. And so if you come to me to sort a sex issue, we will sort it. I will not talk about it. Yeah, you can be sure of that. But the stories are real life, but I've changed a lot so that nobody can actually be identified using these. I have two stories. The first one, 2 weeks ago, I was in a housewarming party for a friend who lives in the US. They sent money, had the house built, and traveled as a whole family to come and celebrate their Kenyan new home. The interesting thing, however, is how I got to meet this friend. It was through a phone call from the US pleading with me to save Mr. John's family. John and Jane are parents of this good friend. John, now 72 years old, came to me for treatment because of erectile dysfunction. He has been off sex for 2 years due to this problem. He had read my column in the Daily Nation and decided to reach out. When I saw John, John is obese, hypertensive, and diabetic. And this is what caused his erection failure. After initial assessment and preliminary treatment, John's erection started coming back, albeit in a weak way. John started making advances to his 60-year-old wife, and that was the beginning of their problems. Jane called their daughter in the US, now my friend who invited me for the house party, and asked her to talk to me to stop treating the erection problem immediately. And her reasons, she gave two reasons. One, she did not want sex anymore. And secondly, her refusal had resulted in a serious conflict, including the man threatening to marry another wife. I asked to see the couple together, that is John and Jane. But when they came to the clinic, Jane requested that John stays out and she talks to me first. She said that when she hit menopause years, the man started having affairs. She tolerated this because she had lost desire for sex, and she felt that she had no moral authority to question the man's actions because she felt she was to blame for not being sexual. She would, however, still occasionally tolerate sex with John for the sake of peace, even though she did not enjoy it. She feared that John would bring disease home. She also feared that the women he was having affairs with would at some point take advantage of him, get children, and claim family property. She therefore felt relief when John's erections failed. She was firm on her request to me. And she told me, if you stand for the welfare of families, you must stop treating John to have erections. So John, on the other hand, had one question for me. What is there to live for after years of hard work if one cannot have sex? How do you enjoy your retirement if you cannot have sex? She accused Jane of being unreasonable and rejecting him, knowing very well that at his age and with erection problems, it was impossible to win and impress a woman in a new relationship. So we had a conflict here. I suggested to Jane that we could get back her sex desire by treating the menopause, resolving the outstanding, social problems, and doing sex coaching to reignite intimacy between them. She simply said no. And I quote her, "There are stages in life. That stage of reigniting intimacy already passed. I do not want to have sex. My age mates do not do such things. Culturally, my husband should be in a different bedroom or his own house at this age." I gave the man homework because I had to find a solution. I told him to go and use his love skills and win back his wife, after which we would re-embark on treating both of them: menopause and erectile dysfunction. Now, remember, so the next time I met them is during the housewarming party for their American, children. And I asked him, "How is it going?" John told me, "I'm slowly wooing her. She's slowly yielding. Progress is slow, but consistent. Very soon, we will be back to you to resume treatment." So I also had a chance to ask Jen, "How is it going?" She said, "He's trying very hard. He's trying to be nice. I am beginning to have mercy on him." And she said, "Let me think of what to do." And then she thanked me for making sure her family did not break by not treating the erectile dysfunction. That is my first case. The second case, which will be faster because of time, Mary, this time, brought her husband to the clinic because she felt there was a big problem in the relationship. She feared that the man had lost interest in her, and as a result, he was avoiding sex. Whenever he attempted to have sex with her, it was unsatisfactory. Sometimes he took long to get an erection, he ejaculated prematurely, and he seemed not to concentrate in the act. He was mean, this is Mary saying, not talking nicely to her anymore, not spending time with her, acting as if he was ashamed of her. The man was 63 years old, Mary was 56. Their children had left home, and they spent a lot of time together fighting. A full medical exam showed a healthy man with no hormone problems. Mary, on the other hand, was in menopause. The man's story was that he was under siege. Mary is no longer the woman he married. And he said this: "She lacked sleep at night and felt annoyed that he was sleeping and snoring. She woke him up many times, which was irritating. His suggestion to move to a different bedroom annoyed her, making her say that he no longer loved her. Chronic lack of sleep made Mary tired. She always lacked energy. She had chronic headaches. She blamed the man of doing nothing about it. Her moods changed erratically. She could suddenly get annoyed, shout, and throw things at him. Sometimes in the night, she threw the blanket away, claiming it was too hot. She did not want her husband to pull the blanket back. She abandoned the hobbies they used to do together, such as going dancing, because she was always tired and sick. She felt annoyed when her husband watched football instead of paying attention to her. She switched off the TV and ordered him to go to bed. She did not feel like having sex and blamed it on the husband. She said he was not trying hard enough to woo him. He was not romancing her enough to feel sexual. She wondered if he had an affair. This made her monitor his movements, check his phones, and try to be around him all the time. And this is what this gentleman meant by he was under siege. So my diagnosis was that menopause was disrupting the couple's relationship, and they needed information on menopause. They needed to be conscious of the effects of menopause. They needed to undergo relationship counseling to reconstruct, the good relationship they used to have. They needed to manage their lifestyle, diet, and so on to reduce these symptoms of menopause. They needed hobbies that could re-energize them and bring them together. And they needed to consider hormone replacement. The couple accepted everything except Mary refused hormone replacement. So, as I come to the end, we can learn a lot of lessons, and I have many of those stories. Because it appears sex is the easier way to intersect with the health system when menopause starts. My first lesson is that menopause, lived experience stories, describe a desperate and neglected problem which affects many members of our society. And it is important to document these stories ethically, and I will continue doing that. Some of the lessons that we learn from these stories, one is that menopause is not just a woman's problem. In fact, it appears the men might even be in a worse situation in their relationships with a woman who is in menopause or undergoing menopausal problems. I think even the children, from what we've heard, are similarly part of the problem when they think their mothers are terrorists. So menopause compromises the quality of life in all aspects, both physically, psychologically, and even socially. The right to satisfying sexual experience seems to be a big part of this, and not many people attend to it. Culture tells us that maybe at menopause you should stop having sex. Science tells us otherwise. Actually, the oldest woman recorded to have an orgasm was 114 years. So it is too early to stop having sex at menopause. Care for menopause is unmet in the health system. I don't want to belabor this point. I think Dr. Serema has already talked about it. But we really need the right to information for everyone involved, not just women, even men. They should be able to know why the woman is going through what she's going through. Even the children. And training of health workers to be able to provide this service currently is a problem. A funded national program on menopause is important because you can't do anything without money. What I see mostly in the clinic is that whenever people come with these problems, even the insurances don't pay. They say this is not a disease, not covered, we won't pay. And this goes with a lot of other sex-related problems. And we need to provide commodities for this issue, the HRT at the lowest level. You know that 80% of our people go to the primary healthcare level. This is sub-county downwards. Those places, if you say HRT, people will ask you, what is that? Even the health workers don't know what HRT is about. We need these things at the lowest level. And finally, routine data collection to help us make a decision of what, every population is unique. Africans have unique experience with menopause. We need to document that. We need to have it in our national database to help us make decisions. As I've finished, let me make 3 requests as I see it. There is a drug called flibanserin. When men lack erections, now we have multiple drugs to give them, and they are able to have erections and have sex. When women are having pain because they are dry, they are lacking desire for sex, we have nothing to give. Right now, there is one drug which has been developed. It is called flibanserin. It's available in the US. It is not available in Kenya. I want to request that as we work on these policies and the drugs and all that Dr. Serem ensures that flibanserin is in the essentials drugs list. Women, do you want flibanserin? Yes. Thank you very much. Secondly, the hormone replacement therapy myths need to go, and we need to use these ethically to solve a problem that we are seeing. I think it is an injustice when we know the treatment and we allow women to suffer these things, families to suffer these things, men, children to suffer these things. I think that is what we call injustice. So again, I want to request as we work on policies that hormone replacement therapy is included in the essentials drugs list. Yeah? That will ensure that it is available at the lowest level possible. And finally, ladies and gentlemen, as I sit, Dr. Serem, I want to attack you. He was my classmate. We are good friends. But his title is Reproductive, Maternal, Child, Adolescent Health. Where is the sex in that? Can we, in this meeting, declare that we will add S to Dr. Serem's title?
Yes.
Thank you.
Thank you so much, Professor. And feel free to leave and rejoin when you come back. But thank you for sharing those two stories. Professor has shared the stories of women who are maybe more privileged. You had their backgrounds. And I think a couple of people here also resonated with it. But I want to call upon Angela Nguku to give the stories of the women whose voices are forgotten. And these are the ones who are in the rural areas, in the underprivileged spaces, using White Ribbon Alliance Kenya. Go ahead.
Thank you, Dr. Wala. First, let me say that I'm very happy to be here. But most importantly, let me say I'm happy to hear everyone talking about their lived experience. Why? Because that is the reason I quit what I used to do to start listening to women first, the real experts, what we call at White Ribbon Alliance Kenya as the real experts. Because they say it's a wearer of the shoe who knows where it pinches most. And for me, I'm a graduate midwife just like Nelly. When I was in the university, no one taught me so many things, including how to take care of women who come to deliver with disability, how to take care of a woman who comes with so many needs after she has finished her delivery, and so many other things. And so as I worked in development for many years, I realized that there was a missing link. And I decided one of the greatest things and the biggest disservice we do is that we start at the top, instead of starting with the real experts. And that's why I founded White Ribbon Alliance Kenya, where we use a very unique approach called the Ask, Listen, Act. We don't go to women with a check. We don't prescribe. We go with an open check and let women decide and tell us what exactly they want. And our surveys are called What Women Want. Ask, Listen, Act is our power approach, because when you ask women what they want and listen to them as they prioritize their needs and act with them, then we get a lasting and sustainable solution. Now, so far we have listened 9 times, 9 surveys, from what women want for quality care, what respectful care means to women, because women told us their quality means respect to them. It means money and everything else. To the last listen, that was actually triggered by 2 conversations I had. I am a certified coach myself, and one of the things you have to do as a coach is to have a mentor coach by ICF. And I have a mentor coach in South Africa, and as I was talking to her last year, she told me, Angela, I can't do anything today. I have brain fog. Every time I go to see my clients, sometimes I don't know what to say, and I wish somebody started talking about menopause. Then she took me back to when I was growing up, and I saw my mom, just like Honorable Justice Joki, the whole idea about my mother fighting us for no reason, quarreling us, and we were like, what is wrong with this woman? What is going on with her? But then that was not it. It took me back 5 years ago when we started doing the campaigns, the What Women Want campaigns. And every time we went only to women who were in their reproductive years. And we had a lot from women asking us, how comes you're not asking us anything after we have finished delivering? Don't you see us? Why are we invisible to the system? That was also the same thing that we had from young girls who are below 15 years, because they're like, you're talking about adolescent pregnancy, but you're not seeing us. How comes no one tells us about anything? But as we were listening to the other 8 surveys, one of the things that stood out was lack of health information. And that struck us, and last year, in partnership with an organization in Switzerland, they funded a campaign called In Our Lifetime. The report is actually out. We launched it 2 weeks ago. In Our Lifetime is a report that reached 97,000 women and girls across Kenya. And we were asking 3 pertinent questions. What do you want most for your health and well-being across the life course and self-care? And today, I want to tell you what I heard from women who have either perimenopausal or postmenopausal. When I was when I was invited to this, I asked Evelyn, I hope you would want us to talk about what we heard from women. Because a lot of times the discussions we have are only held in such rooms, but not in the mashinani. At White Ribbon Alliance, we go across the 47 counties listening to women in all their diversity. Those in the rural slums, those in the urban, the pastoralists, the engineers, the ogieks that you hear about, because they are also women in this country with rights. And let me tell you what we heard. Women are asking for information and awareness. And I will quote what they said. One woman said, we do not want to suffer in silence. We want to understand what is happening to our bodies. Many have said that menopause is not openly discussed, so they want accurate, accessible knowledge in their languages at community level and from trusted providers. I know we pushed and we have asked Dr. Serem for policies, but I can tell you, if those policies continue sitting where the rest of the policies are sitting, then we are doing a disservice. So you and me have a role to play in pushing for rights that reach every woman where they are, not the other way around. So beyond the policy, we need to see action and investments in the same. Last week, my team and I were in Narok and Kajiado for what we call self-care conversations. We use a very different, interesting approach called the talking benches or the Sauti benches, where we listen to women and have intergenerational dialogues, but also sit with women differently as they talk to us about their health and well-being. And I was privileged to sit with women who are postmenopausal, 60 and above. And they told me one thing: we feel invisible. Even in our homesteads, in the society, everywhere, and nobody tells us about anything. We do also screenings for different things, because one of the things that women told us that they want to be screened for different diseases. And let me tell you, as we were doing that, they kept on telling us the many things that they have gone through. Hospital to hospital, nobody is really responding to them. A lot of them are told you are just aging. After you give birth, you just go and rest and wait for your time. And I think for me that is painful. Women told us they want respectful care in healthcare facilities, not being dismissed as what I've just told you, just aging, but taken seriously when they present with symptoms like hot flashes, bone pain, or emotional stress. Let me tell you, listening to those nomadic women was really painful for me, because they're like, they go, they come, and when we try to tell them, to inform them and tell them what we are feeling, they're like, every woman goes through that. You're just being lazy. And by the way, all of us are going there. One time I was listening to a conversation sometime during a Women Deliver conference, and one of the women told us, the only thing we can start talking about is old age, because it's cool. All of us are going there. So whether we are there, it's only a matter of time. The difference is time. Women want mental health and psychosocial support. They describe feelings of shame, isolation, or loss of identity during this stage. They have no safe space to process it. Nobody listens. They are dismissed everywhere. And maybe we are better off because we have people that are going through the same thing with us. Those women have nobody in their homesteads. They are just dying slowly. Their quality of life is poor. They want affordable and available treatment options for symptoms, including hormone therapy, nutritional support, and counseling. Actually, we are the ones who ask them about hormone therapy. To them, they have no idea. So we are like, do you know that there's this thing? Do you know? They have no idea. In fact, even the healthcare workers have nothing. And I think we can attest to that if you have been working with women, or you are trained as a health worker. Even if you are taught about it, it's rushed. It's not something that is central. But most importantly, they want menopause to be framed as a life stage, not an illness. Women ask that health systems acknowledge this transition with dignity, just like pregnancy and adolescence. And I think I will tell you, I think I learned this question by one thing that women asked us. They told us, and this is in our report, and if you have, I wish I'd come with some copies for you to see. And I think there's a video that will be played at some point of one of the women from Narok who told us something. Women told us that we are tired of being seen as reproductive machines. We want to be seen as a whole, from pre-adolescent all through to post-menopause. And I hope today that we can be able to respond to the 97,000 women and girls across 47 counties in Kenya, in all their diversity, who spoke openly without fear or shame on what they want for their health and well-being. Thank you.
Thank you, Angela, as always advocating for every woman's voice through White Ribbon Alliance. Okay, we shift gears a bit. Prof, women have been called terrorists. We've called our mothers terrorists. We've been told we are sluggish. Others have confessed they have foggy brains. I actually have to walk around with a notebook and a pen because, yeah, and when I meet people, I say, please remind me what your name is again. I have stopped feeling shame over that. So we talk about mental health and perimenopause and menopause. And I think at some point, Professor Kihara will also break down to us what's perimenopause, what's menopause, what's postmenopause, because those are three different life stages, yeah? So Prof, over to you.
Thank you. And I know, right? It's a very comfortable space to be in. I want to thank you, Angela, for framing this correctly. And where you finished is where I would begin. That, and you'll forgive me for saying this, all, bar none, all our policy and legislation, and Madam Joki, you will confirm, treat women as reproductive machines in this country. That's where we begin. So we can talk as much as we want here, but the laws of this country that have anything to do with women, the constitutional provisions that mention women explicitly, they deal with them as reproductive machines. And once you stop being reproductive, you are erased from our social setup. So that is something that we might have to think about going forward. And this emanates from our social and cultural environments, which cannot conceive of women as anything other than reproductive machines. And so you have to start confronting those cultural underpinnings of our behavior, the religious background of our thinking, and how we have set up our governance system. Because everything is about the fact that we argue about whether how women should have sex, when they should have sex, with whom they should have sex, what happens after sex, what happens to the products of sex. We legislate all that. We've put it in the Constitution, Madam Joki. And that's where the problem starts. And then I will pivot from society to the brain, and I will tell you that the human brain bathes in a soup of chemicals. That is what the human brain bathes in. And this soup of chemicals that our unique brains bathe in is dependent on the function of other body organs. And there are body organs that are far away from the brain, including the reproductive organs, the ovaries, the testicles, which produce chemicals that make their way to the brain, and they become part of what bathes our brain. And our brain is made up of nerves that communicate through electrical signals, which are influenced by the soup in which the brain is sitting. And so how we behave is influenced by the composition of that soup in which your brain is bathing. And therefore, when that environment, that chemical environment changes, the things that we call hormones, when the ratios of those hormones changes, their interaction with our brain influences how we think, how we feel, and how we behave. That is a biological foundation of behavior. And menopause is perhaps one of the best examples how our mental health is affected by our physical state. Because a lot of the feelings, thoughts, behaviors that women going through menopause, which is really a product of hormonal change at a certain stage of life, how they feel and behave is influenced by that change in the soup in which the brain is bathing. And therefore, inevitably, there are consequences. Some of these consequences are tolerable, so people can live with them, and some of them are disabling and impairing. When do these changes occur? When I was asked to speak a little bit about what are the common mental health issues or impacts around menopause. And I asked myself, when do those changes in the soup that bathes the woman's brain, when do those changes occur? So again, looking from inside out, they occur at a time of great change in the life of a woman, which induce multiple anxieties, some of which are not necessarily related to the change that is happening in the brain. Menopause occurs at a time when, for many people who have families and children, when the children are becoming or have become adults and are leaving the home and have their own lives to take care of, and they have their own children. And your role as a parent has to change. And how you interact with your offspring and their offspring has to change. But change is difficult because you have been used to doing things a certain way. Menopause also occurs at a time when many people who are fortunate to have older relatives or parents are taking care of parents who are much older and experiencing the vagaries of life. These bodies tend to become frail as we age. They get chronic diseases, they get disabilities. And menopause is happening to you when you're taking care of older relatives who are going through those changes themselves. So that is another reason why it's an interesting part of a person's life. Menopause also occurs at a time when many people are sitting back and taking stock of what they have made of this life and what this life has meant, because you've done so many things, and what impact have you had in this life. And for some people, interrogating what they have done with life can produce certain anxieties, because then you start worrying about the things you haven't been able to do that you thought you ought to be able to have done at that point in your life. As has been mentioned severally, menopause also occurs at a time of social changes, even in relationships. So whatever relationships you're having, whether it's with a spouse or with relatives or with friends or other family members, there are changes that are happening socially around that time anyway, menopause or no menopause. And that is the time that you're also experiencing menopause, and these changes are happening. And so when one is thinking about a person going into menopause, person experiencing menopause and post-menopause, you cannot think about that period in isolation. You cannot think about it only as what is happening inside a person, but you have to think about this person, the environment, holistically, as a part of a greater whole. And therefore, some of the features, some of the symptoms that emerge during menopause not only affect the individual who's experiencing them, but they also affect their social environment. So issues like lethargy, which is common during menopause, because the hormones that are produced before menopause, they help you to harness energy, to focus your energies, to do the things that you think are important to you, and so on. When there's fluctuations in those hormones, then there's lethargy and difficulty doing the things that you would normally be able to do. There is cognitive slowing, what we are hearing people call brain fog. A difficulty in following through with plans, memory impairment, and so on and so forth, which also have to do with those changes that have happened in the hormonal environment in which your brain is functioning. There will be sleep changes. Because again, those hormones interact with other chemicals that regulate when you sleep, how much you sleep, and how much rested you feel after you sleep. There is the heightened senses. Uh, I see the women here smiling. The heightened senses. So, this might be a normal, nice, lovely touch when you're 25, 30. But then it's like a blow when you're at a certain age. So there's that heightened sensation, both of touch, heat, all sorts of sensation, even sound, and so on and so forth. So those are because the brain was bathing in a different environment as you are thriving and growing, and now it is bathing in a totally different environment, and it is having to deal with it. Remember, the brain is blind. The brain lives inside a dark chamber inside your skull, and it only knows what's happening out there through those senses. And so when it is getting hyperstimulated, it goes into spaces where you protect yourself because the environment out there is harsh, and it doesn't know any better. There's emotional lability. I mean, this means your emotions, sometimes you don't feel like you are fully in control of them. All right, so sometimes you want to be happy, but then you're not happy, yeah? My son has graduated from campus, and I'm supposed to be there cheering and so on, but I'm not feeling cheerful. And I don't know why I'm not feeling cheerful, because I should. Everything says I should, but I'm not. And it changes like that, and that's a common feature of menopause. So when you have all these features that I have listed, accompanied by the physical changes of menopause, then those are quote unquote normal psychological occurrences during menopause. But then we have things that become less adaptive. So sometimes we diagnose depression during menopause. And this is a person who has the features of depression, they meet the full clinical criteria of depression, and the symptoms have emerged during menopause. And the same with anxiety and increased risk of suicide in this population. Okay? So often what the research says is that this, what we might call pathological findings in menopause, when I see them in a woman going through menopause, I take a history, and often you will discover that a person who is being diagnosed for the first time with depression during menopause, a significant proportion of them have had depressive symptoms even before menopause. And therefore, menopause might be exacerbating or triggering episodes of depression. It might not necessarily be the cause of depression. And the same with anxiety, and the same with the risk of suicide. So I think this is framing the common psychological and mental problems that one might expect to experience as they go into menopause. And to say, so for the ones that I mentioned about lethargy and so on and so forth, there is treatment, as my colleagues have talked about, hormone replacement and social and environmental changes and diet and so on and so forth, and exercise and so on and so forth. But then when we diagnose clinical depression, anxiety, suicidality, then there are mental health treatments as well for those that would go in tandem with management of menopause. I do know that I have probably very little time remaining, but I think there's a part of this that has to do with integrating mental health in the care for menopause. And speaking as a mental health advocate, I think I do not narrow it, and I was having a conversation with a colleague, and I said mental health must be integrated in all aspects of health and in all aspects of life. Because it begins with promotion, which has to do with eating healthy, physical activity, social connection, mindfulness. This is promoting good mental health, whether you are in menopause or before. We talk about prevention. This is early identification of problems. Having access to counseling services, creating a social network, taking care of those, the pombe, cutting down on that, substances and so on and so forth. And then talking about issues, having a forum to talk about it like this. It goes into treatment, which is identifying those problems and providing treatments. And treatment is not only medication, but it can be social interventions, changing your environment. It can be psychological treatment, and it can also be medications. And finally, speaking about stigma, I think for stigma, we have to talk about addressing ignorance, and my colleagues here have talked about increasing access to information about mental health and about menopause as well. They've talked about addressing prejudices, that is changing our attitudes towards mental health, both towards mental health itself and to those who are suffering with mental ill health. And we've talked about discrimination, addressing discrimination through social norms, taboos, but also through legislation and through policy. The final thing I would say for menopause care, from my experience in mental health, I would say this is not an individual's problem. So when you're addressing the problems of menopause, please include families in these conversations. Please include the social network of this individual in those conversations so that they become part of the social support network that helps the woman to deal with the challenges that they face during menopause. Thank you very much.
Thank you so much, Prof, for reassuring many of us that indeed some of these things are real and that we're not imagining, we're not just being difficult at work, in the house, that these are chemical imbalances that are triggering and some really do need attention. Asante sana, Prof. Okay, so we shift gear to Professor Ann Kihara, who will talk to us about how do we address all this? So we've had the woman from Kajiado, we've had the couple who does not want to be touched, and we have people experiencing real mental health issues based on this. Is there a solution or do we grin and bear it? Go ahead.
Oh, we certainly have solutions, and thank you, Wamakobe. I'm coming with a different context. And I want to start by defining what is menopause, premenopause, postmenopause. Menopause is just a cessation of periods. Your periods stop. 1 year, no intervention in terms of family planning methods or other drugs being used. It is a natural phenomenon. You were young, you had your ovary, at puberty you start your menses, and you begin to acknowledge you can be reproductively active. By menopause, periods stop, your reproductive clock has closed. But it's not always an aging process. I want to put this very clearly. You have those who will go into premature menopause. Why? I'm on cancer therapy. Or I have done surgery on you, especially when you've had conditions like endometriosis, deep-seated endometriosis. You've got scarring on that ovary. And I may be forced to even move it out, or the interventions of surgery just cease it to function. And this can happen very early, ladies and gentlemen. A 34, 40-year-old. Or you had a hysterectomy and we say, your ovaries were not looking too healthy, I had to come out with it. What have you done? You've crushed the estrogen production. And principally, that is the hormone that keeps all these ladies looking very beautiful. Very beautiful. It's your estrogen. Then come through the natural process of aging. The ovary is reducing the production of that hormone, but the body clock is beautiful. You start beginning to gain weight between the lower part of your chest and the upper part of the lower part of your pelvis. Why? That fat tissue is actually a compensatory mechanism to produce the estrogen you need. So when you start gymming and you start finding this isn't quite going away, it is because that's a compensation happening. And then you have the lady who, in the premenopausal, which can happen anything between 5 and 10 years before menopause, which you now know. And then the post-menopause is about the 10 years after ceasing the menstrual period. That's the period. We call it climacteric. Please don't confuse it with my sexologist. But that's the period in which really hormonal replacement therapy can make a difference. I hope we're getting it very clear. Now, what happens with the lady who has premature ovarian failure? And especially noting it may be a much younger girl or lady. I have to start complimenting her. Why? Why do we do this? You've talked about the brain fog. And Honorable, I really liked your story because we go through it. I'm still on pen and paper to date, huh? Just to make sure I get it right. But you have the brain fog if unaddressed as a result of menopause and your happy hormones. He was talking about happy hormones. We don't want to get too technical. But there's some happy hormones that dance. Your dopamines, your serotonin, they're beautiful hormones. I mean, the milieu, the environment the brain is bathed in, that keeps you a happy soul. Now, when menopause comes and estrogen goes and your happy hormones decline, now you begin to see those mood swings, temperaments, concentration deficits. In its worst, we talk of Alzheimer's or the dementia, which he has to deal with, which families have to grapple with. So that's one big problem you would wish to avert. You have to start upstream. The other is cardiovascular disease, heart problems. The other one is now the bones that creak and you begin to behave like a robot. When you're asked, stand by Nelly, give me time. When it's really on a bad day and cold like it is, you can see some of us are wearing very warm clothes. Not out of choice. You want to keep warm because those bones are not moving as agile. A lot of people will present with fractures. Any small fall or displacement, it just snaps because the bones have weakened and cracked up. So those three things, the bone issue, the brain issue, the heart issue. But let's compound this. This is also the age we're beginning to see diabetes raising its head. We're beginning to see cancers raising their head. So you have other cocktails of things that may surround this particular time phase. And then you have the relational issues. I don't have to belabor to that. But your partners, your children are leaving the nest in a lot of the families, particularly in your post-menopausal year. And for women, there is a give that has to happen. And sometimes it's very painful. So, what is the role of HRT? Simple. I'm replacing particularly estrogen. That's the main hormone. But I also have to know, do you have a uterus or not? Because if I bombard you with just estrogen, I may actually end up giving you a predilection, let me use the word predilection, to getting cancer of the lining of the uterus. So a lot of us will give a combi pack of estrogen and progesterone. So some people will get cyclical withdrawal bleeding. A lot of women don't want that. I'm done. And this is the reason we've progressively reduced the doses of those drugs so you don't end up with a period that you had ceased having. Why am I mentioning this? If after menopause, you're being followed up whether you're on HRT or not, you're getting post-menopausal bleeding, it could be heralding a problem, particularly cancer of the reproductive system. I don't want to say just the uterus. The uterus can have cancer. The ovaries can have cancer. The vaginal lining, even the cervix, they all give us postmenopausal bleeding. So when you have menopause, please, any woman, the first thing you need to know, if my periods return and they had stopped, that's a red flag. I hope we're together. Now, I'll advance it even more. Testosterone. We have an amount of testosterone we release as women, particularly in your mid-cycle during your reproductive years. And we do use testosterone supplements, particularly when you have issues with libido. Low dose. But we know you have to have it monitored by your doctor. Too much of anything is a poison. We're in an era, and I really like the fact, Goko, you went up north. Climate change, environmental toxins, we don't talk as loud, but we know it is beginning to even affect our endocrine, our hormonal environment. So we've got to start paying more attention. So I'm not surprised she gave the story she's given. The sense is there. Do we have HRT in this country? Public system? No. And I hope, Honorable, you're noting. Yes, we have our essential drug list in this country. Estrogen has actually been put in place, and if you look at the latest publication of 2023, it has even been given an indication for hormonal replacement therapy. The progesterone, we have some tablet, but we do not have definite HRT medications are 1, 2, 3, 4, as I've alluded to. Okay? So we're wanting private system, private insurance, and particularly the really beefy ones, you may be able to access the medications. Am I right? But these are the girls with premium package. What do I do with Mama Mboga? What do I do with the lady in the rural village? So some of the things people are misusing, and please put it loudly in the airwaves, are family planning tablets. That is wrong. That is wrong. Because family planning tablets have got different preparation, which has got much higher doses, which have a wrong effect to your system. HRT is just that, hormonal replacement therapy. Much lower dosage and either given consequentially or cyclically. That's one. Do we have testosterone preparations? Nada. So what have women recourse to? And I think all the ladies in this house will be very familiar. We take alternative medicine, cocktail. And I wouldn't mention names, but pyramidal schemes do exist. Yes or no? Do we know them, ladies? And you're told, okay, you can take red clover, you can take evening primrose, you can take, I can go on and on with these alternative herbal and natural things, including soya. Now that one everyone knows. Soya. They do have a role, but to be honest, have we done proper research to look at it in our context? Nada. The other thing I must mention, Honorable, and this concerns me, is all these things that have raised their heads we're not talking about. The Botoxing, the fillers, the facial lifts, the breast augmentation, the liposuction. Now you've understood where I'm coming from? Question is, what is the regulatory framework that we have? And is it right? We have even seen calamities that have happened, haven't we? So we've got to think holistically and not just at HRT, because this is also a time self-image becomes a problem. And women definitely always want to look nice. At 80, I want to still look good, Dr. Monda, don't we? So that's what I would want to say about this question. Conflicting information, misinformation, disinformation, inappropriate, sound knowledge. The second one, how can we improve access to safe, affordable HRT in Kenya? We've talked policy, policy, policy. Policy is not operational. We must have guidelines. We must have algorithms. I've talked about the woman with or without the uterus. But we have to add layers. In some women, before you even give hormonal therapy, find out the family history for breast cancers. Find out if she's already having post-sexual contact bleeding, which may actually be heralding that there is a problem at the cervix. So you must look at the patient history. You must know how this patient is through laboratory investigations. Now, the laboratory investigations, I'm coming to insurance because she's seated here. It's a whole bombardment of investigation. I need to know your BMI. I need to know your lipid profile. I need to know your sugar. I need to know how your thyroid is behaving because they all have a bearing. Now, that cocktail of tests, honestly, honorable, it is impossible for Mama Mboga to afford it. It is impossible. But it must be done because some of the drugs have got a bearing on the liver. And I need to know how it is. I may be on other treatments because I am a diabetic or I'm a hypertensive. So you have to look at that. Then we have the issue around choosing the route of the medications. Increasingly, we're moving away from you gobbling it up. We want to use transdermal, so patches, gels, creams, because they don't affect you elsewhere. They work where they're supposed to work. So we have to be able to decide with the individual. It is individual. So I come again to Honorable, and I come again to Evelyn and to Nellie and to Angela. Do we have well women clinics? I've always said, where is the Golden Girl Clinic? It doesn't exist. I'm over 50. Where's my Golden Girl Clinic? So that I can have this executive screening and checkup. Most of us stop when we stop giving birth. That's it. I never see you again. And when I do see you, I'm dealing with rheumatic problems, brain problems, cardiovascular issues. They've already set in. And even then, they may not ask about your menopausal or your gynecological history. So, well, women clinics. Because really, we've got to start having an entry point at all levels of care for women so that we can begin to have this conversation. Monitoring and follow-up. Please, I don't want you to leave here with a blanket that everybody can go onto HRT. Some of us did not experience hot flashes. I don't know what it is. Some have nightmares. I will not mention who is asking me, what do I do? Yeah? So some have nightmares. But every woman experiences a transitory issue. This is an ideal time to even do screening for particularly reproductive cancers, and please do not forget the breast screening, which we really say start at 40 if you haven't done your basic mammogram. So we have admins that can add value for our women, and therefore it can improve access and safety. We have endocrinologists. Gynecologists ideally should be dealing with this entity because it's a continuum of her care. But endocrine people tend to come in because we tend to see them for diabetes, for my hypertension, for my thyroid problems. So that's a complementary group we should be working together with. Mental health, we should be working with. So when I'm talking about a well woman clinic, it should be multidisciplinary. Must be. Reviews, follow-up, 6 monthly to begin with, and then yearly, if you have no problem with your HRT. HRT does not go on forever, amen. For some women, they'll use it for a year. For some women, 3 to 5 years. For others, they may have to use it a little longer. It's individualized. I don't want you to go there with a blanket. Then, what safeguards should I plan to have to ensure safe prescribing? That's the easiest question to answer. I have a policy framework. I have guidelines. I know how to actually put an algorithm on any woman. Screening, diagnosis, management. And I want to bring in the male because honestly, you are partners and allies in this war. You must walk with us, understand us, have public education forums, have forums where we also undertake localized Kenyan research. So here, I'm even looking at Ministry of Health. Mary is here, Magumbo. I know you'll get the message to my friend. Yeah? We have to start a registry on menopause. We don't have. We just don't have it. And what's not documented is not. Yes. Number two, we have given too much leeway to the quacks. I'm sorry to say. The quacks. Wherever there's a hiatus, you don't fill it, somebody will come up to fill that space. So those commitments there, honestly, I will be prepared to run. Because menopause has been a neglected area and it has to change. I'll leave it at that.